Hello everyone. Today's topic is the pharmacology of coagulation disorders. These are the learning outcomes. Okay, so before we really get into the medications, let's review very quickly coagulation pathway. So recall from your basic anatomy physiology courses that anytime we have a ruptured blood vessel or injured blood vessel, let's say this is the injury site. So what will happen is blood is going to start leaking out, right? So in order to prevent us from bleeding to death, if you will, we have a natural phenomena, if you will, that we will cause spasm, vasospasm. So anytime you have a ruptured blood vessel, it's going to cause vasoconstrictions, you can say. And the idea behind vasoconstriction is that we are going to decrease the blood flow to the injury site, right? Okay, now at the same time, what will happen is platelet will start running towards the broken or injured site to make some kind of a plug or try to make a clot, you can say, right? So remember that platelets have natural affinity towards the damaged blood vessel. So they stick together, they clump together, right? They aggregate together, whatever you want to call them. The idea is to make a clot, right? But this is very weak clot at this time. Now, in order to make a very good clot so that we do not keep bleeding, both intrinsic and extrinsic pathway will be activated at the same time. So we'll start with the extrinsic first. So if this is the injury site right here, factor 7 will combine with tissue factor, and factor 7 will get converted into 7A, that's activation form of factor 7. And with the help of tissue factor, factor 10 will get converted into 10A. So far we got into 10A. So I'm going to put a big old circle here, and I'll come back to this point again. But let's go back to the intrinsic pathway for a second. Now, intrinsic pathway is starting with the factor 12. So these are, by the way, Roman numerals. When we talk about the factors, they're always written as a Roman numeral. But to make my point, I'm going to use Arabic number for a second. So factor 12 will get converted into factor 12A, that's activation, right? Activated form. After 12, we have number 11. After 11, we got number 9. And then we realized that, oh gosh, we forgot number 10. So I'm going to put number 10 here. So the point here is factor 12 gets converted into 12A, then 11 into 11A. We forgot 10, so we put 9 to 9A, and then we realized that, oh gosh, we forgot 10, and now we got the number 10 back here. Now 10A gets converted into 10A. 10 gets converted into 10A. Now this is the site where both intrinsic and extrinsic pathway, they meet, and they will help factor 2, which is prothrombin. Another name for factor 2 is a prothrombin, will get converted into 2A, and the fancy name for 2 is a thrombin. This step is very important and has a special name called prothrombinase complex. All right, so this will help eventually to help factor 1, which is a fibrinogen, to get converted into 1A, which is a fibrin. And fibrin will cause or make, you can say, a very good solid clot. So the whole point of activating so many factors was to get a solid blood clot. And it all started with an injured blood vessel with the help of platelets and activating both extrinsic and intrinsic pathways. Okay, so this is everything that I just mentioned. You have this as a as an outline, if you will. So now with that understanding, let's talk about some disorders. So if the idea is to make a blood clot, we can have two different types of issues. The first one on the list is thromboembolic disorders. That means that your body is going to make too many blood clots, right? And that's not a good thing. Remember, everything has to be in balance. We need to make blood clot when we have a source of bleeding, right? In the setting of bleed, I can say. But if all of a sudden body is developing blood clot, that can be a problem. Then we can have DVT or pulmonary embolism if that clot travels to the lungs, right? So what are some conditions or risk factors that can put our patient at a high risk for developing these thromboembolic events, if you will? Well, if a client or individual is immobile for extended time frame, so for example, driving for many hours without taking any breaks, right? Or long flights, if you will. Or any type of trauma or a surgery. Let's say you underwent a cabbage or some kind of abdominal surgeries, and now you are not able to walk, and maybe due to pain, or maybe it was a right knee replacement or a hip replacement. So any type of surgery can actually put you on at risk for developing blood clots, right? And those clots can travel to the lungs and may cause pulmonary embolism, or may have some hypercoagulability state. So one thing I can think of right now is maybe cancer. If a client has a cancer, that client is automatically at higher risk of developing a blood clot, and especially if they are not able to ambulate. Now you're talking about multiple factors, and some drugs can also cause blood clots, if you will. Like a contraceptive, I can think of, as a drug, as a class, or maybe some seizure medications and so forth. Okay, so the second type of disorder is coagulation disorder. This is the opposite of the first one. This is where you have a client who is at risk of a bleeding. The first category was when the client is at risk for making blood clot, right? So now too much bleeding is also a bad thing, as we know. These disorders are usually caused by decreased number of platelets. So maybe you have thrombocytopenia due to bone marrow suppression. Your bone marrow is not making enough platelet, or maybe you have a folic acid or B12 deficiency, and sometimes liver failure. Maybe you have liver cirrhosis or liver cancer, maybe hepatitis, or liver damage due to alcohol. Anytime you have liver disease, it will put you at higher risk for coagulation disorders because of multiple reasons. Number one, decreased platelet levels. Number two, maybe increase INR, decrease clotting factors. Remember, we just talked about that we have to have a clotting factors to make clots. And in the setting of liver disease, you have a decreased level of clotting factors to begin with. Now that's one reason patient may start bleeding, and the second cause could be increased destruction. So maybe the issue is not the production, but we are destroying it at a faster rate. Thrombocytopenic purpura or DIC. Or maybe it's due to medication the patient is on, like a heparin-induced thrombocytopenia. So overall, when we assess our patient, we ask about any source of a bleeding. When you brush your teeth, gum bleed, nose bleed, bleeding from the ears, GI bleed, blood in the urine, any source of bleeding, or maybe petechiae and so forth. So that's a good assessment skill to rule out these disorders and do further workup, of course, right? Okay, so for the purpose of this presentation, we are really going to focus on clotting disorders, because we are going to talk about some drugs that will prevent those blood clots. So the main topic is really anticoagulation today. We have options. We can either give medication through IV or sub-Q injections, or maybe by mouth. So we have two main examples that I want to talk about under either IV or sub-Q, and that's heparin or and low molecular weight heparins, such as Lovenox. And then we'll talk about PO drugs, Warfarin, and some other NOAC drugs. So we'll start with the anticoagulation therapy with heparin first. Heparin is naturally present in the liver and in the lining of blood vessels. The mechanism of action for heparin is that it will activate the enzyme antithrombin 3, which is a natural anticoagulation in the blood, as I mentioned earlier. And this enzyme, when you activate it, will inactivate clotting factors, clotting factor 9, 10, 11, and 12. By doing so, it will inhibit the conversion of a prothrombin to thrombin and prevent thrombus formation. Now, remember, we just talked about that. At the end of the day, we are trying with the clotting factors. We were trying to make a blood clot. Now, these are the patients who are already at higher risk of developing blood clot, or they may already have a blood clot. So the idea is to prevent those blood clots. So we can inactivate those clotting factors that are responsible for making prothrombin or converting prothrombin to thrombin, right? And eventually do not allow the body to make a thrombus formation or clot formation, you can say. Heparin is 1,000 times more active in inhibiting thrombin, factor 10A, factor 9A, and other substances. So very powerful drug, you can say. Now, because it's a very powerful drug and it's going to inactivate many clotting factors, needless to say that the client who's on heparin will be at high risk of bleeding, right? So very critical drug, you can say. So what we do is, for safety standpoint of view, we monitor APTT levels, and APTT stands for an activated partial thromboplastin time. Normal range for somebody who's not on heparin treatment, so like healthy individual like you and I, would be 25 to 35 seconds. So that's a normal range for APTT. Now, if you have a client on heparin, we would expect their range to be a little bit higher, than their levels are going to be higher because we are blocking their clotting factors, right? So recommended therapeutic range for a client who's on treatment is going to be 1.5 to 2.5 times the baseline of that client. So for example, 60 to 80 seconds if the normal range for that client was 25 to 30, or baseline I should say was 25 to 35 seconds. Now, what happens if the levels come back as elevated, high level? Well, we need to, number one, stop heparin at that time, and number two, we will give them a reversal agent. Protamine sulfate will reverse the effect of heparin at that time. So very important drug and very critical drug. Remember, increased level can result in prolonged bleeding. Okay, so the second drug under this category is low molecular weight heparin. Generic name enoxaparin, brand name Lovenox. Now, what happened is you may come across a situation where the patient needs to be on some kind of anticoagulant medication, and perhaps they were already on heparin, let's say, but we are going to discharge this patient from the hospital to home or nursing home or room and board and so forth. And it is not practical to continue heparin, especially IV heparin, as an outpatient because it requires blood monitoring. So they are a good candidate for Lovenox. So heparin molecule is changed or shortened and modified to create this class. So mechanism of action is very similar to heparin, except the shorter heparin molecule is now unable to bind with the thrombin and making this drug more selective for factor 10A inhibition. So the overall goal is still the same. We are going to prevent blood clot, but instead of binding to thrombin, we are going to inactivate factor 10A. The main difference between heparin and Lovenox is, number one, this is not IV drug. This comes as a subcutaneous medication. Both heparin and Lovenox are not PO drugs. Okay. Heparin is weight-based dosing, usually 2 times a day, and it's a 10 times less heparin. It will cause 10 times less heparin-induced thrombocytopenia. So safer drug, you can say. More expensive. Most of the insurance companies actually cover the drug, and the beauty about this medication is that it does not require APTT monitoring. Okay, so the third agent is fondaparinux, which is a generic name for brand name Rixtra. The mechanism of action is that this drug will inhibit factor 10A. By doing so, it will prevent blood clot. It comes as a subcutaneous injection. This is a synthetic drug with a longer half-life and has a less bleeding complication than the previous drug that we talked about, low molecular weight heparin. Now, remember we started our story with heparin, which I said is a very, very strong medication, potent medication to prevent blood clot, but carry very high risk of bleeding, and we require blood monitoring for that drug, right? And then for the second drug, low molecular weight heparin, we changed the molecule. We shortened it by 1/3 of heparin and made it a little bit safer, if you will, remember, and that did not require any blood monitoring. Now with Rixtra, we changed the formula in a way that it provides a longer half-life and is considered very, very safe. But this drug is more expensive than the first 2 drugs that we talked about. Okay, so far we discussed 3 agents that were either IV or subcutaneous injections. So now we will talk about a drug that can be taken by mouth, PO agent. Warfarin or Coumadin is the agent. Before we really get into the pharmacology, I want to share a very interesting history lesson here that will help us to understand how we discovered this agent. He will not be tested on a history lesson, by the way. Okay, so what happened was in the mid-1930s, there was a farmer who reported that most of his cows were dying, and they were eating sweet clover hay that he reported that had some mold growing in it. He got frustrated and he showed up at a lab at University of Wisconsin with a can of cow's blood with him. He told them that, you know what, my cows are dying and they're eating sweet clover hay with some mold growing in it. Here's the sample, help me. Well, after years of experiment in 1940s, the scientists, they concluded that the fungus was causing blood to be thinned, if you will, and they named that substance as coumarin. They realized that they can develop a medication to kill rats the same way this drug was killing, or the substance was killing cows, that is to bleed to death. So they developed a tablet called number 42 that was sold as a rat poison, if you will. Well, later on, they changed the formula and made a drug a little bit more safer to prevent clotting disorder in humans, and that gave birth to our modern medication called warfarin or Coumadin. Okay, so the mechanism of action for this drug is that it blocks vitamin K. So how does that help? Well, remember that there are some factors, the clotting factors, that are dependent on vitamin K. More specifically, factor 2, 7, 9, and 10. These clotting factors are dependent on on vitamin K. So the way I remember is factor 2, 7, 9, and 10. So 2 plus 7 is 9, not 10. So this helps me to remember. Hopefully this will help you as well. All these 4 factors are dependent on vitamin K. So if this drug is going to block vitamin K, that means we will not be able to make blood clot. This medication is very commonly used a drug to prevent DVT or to prevent PE or to prevent a thrombotic event in the setting of AFib, or if you have a client with a prostatic heart valve patient. It will also decrease the risk of recurrent TIAs or MI. And please also understand that this is a pregnancy category X. So warfarin tends to not get along with other agents. There are many drug interactions, or drug food interactions, drug herbal interactions, if you will. So we'll start with some seizure medications. Generally speaking, most seizure drugs such as carbamazepine, maybe phenobarbital, they will decrease anticoagulant effect of warfarin. In other words, if you're taking seizure medications along with the warfarin, seizure medication will slow down or decrease the therapeutic effect, and putting these patients at risk for blood clots. Same is true with oral contraceptive medications. You have to be very careful. Generally speaking, oral contraceptive medications carry a risk of blood clot. Okay. Now, food that is high in vitamin K, such as green leafy vegetables, for example, broccoli, cabbage, lettuce, and so forth, they will also decrease anticoagulant effect. Remember, I said the mechanism of action of warfarin is that it blocks vitamin K. So if you have a client who's taking warfarin and their diet is rich in vitamin K, then you're going to decrease the effect of this medication, putting these patients at a high risk of developing blood clots. Generally speaking, we tell our patient to eat fresh fruits and vegetables. So we don't tell patient not to eat salad, if you will, but we tell them to be consistent. Do not increase or decrease intake of these vegetables to avoid any sudden fluctuations in the PT-INR. We'll talk about PT-INR in a second. Okay, there's a herb called St. John's wort. People use this for depression, and if the patient is on warfarin, this medication will decrease the effect of warfarin, again putting our patients at risk of blood clot. These first 3 items that I discussed so far will decrease INR. We'll talk about INR in a second. That means decrease the therapeutic effect, equal increase blood clot, or at least risk of getting blood clot. Now, the following agents either drugs or food will increase INR or increase the risk of bleeding. It's opposite now. So for example, ginger, garlic, glucosamine will increase risk of bleeding. Some drug interaction like a heparin, aspirin, these are, you know, like a blood thinner, if you will. This will also increase bleeding if you're taking, especially if you're taking with warfarin. Some antibiotics such as cephalosporin or sulfonamide. If you have a patient on, let's say, Bactrim for UTI and also taking warfarin, that antibiotic Bactrim will decrease the effect of warfarin. Increase the effect of warfarin, putting our patient at increased risk of bleeding. So it will increase INR, equal increased risk of bleeding. So what is INR? Well, PT INR, prothrombin time, or INR is international normalized ratio, is a way of measuring the therapeutic effect of a medication. So generally speaking, INR on a healthy individual, they should have INR less than 1.0, let's say. If you have a client who's on warfarin, we expect their INR to be greater than 1.0, right? Because they are on medication, right? So normal range for that patient is usually 2.0 to 3.0, so 2 to 3, right? If INR is less than 2.0 for somebody who's on medication, we call that subtherapeutic. If PTINR is less than normal. However, if INR is more than 3.0, let's say it's a 5 or 6, we will call that supratherapeutic. So supra is more or increased level of INR, and subtherapeutic will be decreased level of INR, and 2 to 3 is your normal therapeutic range. If your client is giving us a sign and symptoms of a bleeding and they have increased INR, we of course hold warfarin and plus minus give vitamin K. Vitamin K will be antidote for warfarin. It will reverse the effect of warfarin, you can say. So so keep that concept in mind. Supratherapeutic, subtherapeutic, normal range for these patients. So again, this is the same thing that we talked about, that normal range for PT, which is a prothrombin, is 11 to 13 seconds. But right now we have a standardized way of measuring PT test, if you will, and that standardized way is international normalized ratio, that's INR, and normal we talked about that it's less than 1.0, right? But if the client is on medication, for them the range would be, therapeutic range would be 2 to 3. All right. All right, well, next category is a NOAC. These are novel oral anticoagulant medications, since they were newer than the old standard warfarin treatment. They have also been listed as DOACs, that is direct oral anticoagulant medications. So the examples are Xarelto, Eliquis, or Pradaxa. These are brand names. Remember the issue with warfarin, which is a wonderful drug, by the way, very effective, but the main issue is that narrow therapeutic range. Remember, it's a range is 2.0 to 3.0. So on any given day, if you are not within the range, if you're up more than 3.0 supratherapeutic, you are at risk of bleeding, and then if you fall below 2.0, you're at risk of blood clots. So and both options are bad, right? Bleeding is bad and blood clots are also bad. And there are some patients who may not be a good candidate for warfarin, maybe because of not able to do lab work that frequently. If I want to monitor on a weekly basis, maybe lack of transportation, or just not practical for those patients to be on warfarin. So now we have options for those clients. So there are three options. I have so many patients on Xarelto now, and even for Eliquis, for DVT and so forth. Xarelto, their mechanism of action is that they are factor 10A inhibitors. A contraindication is creatinine clearance of less than 15 ml per minute. So we keep an eye on the renal function. Eliquis, Abaxapan, factor XA inhibitor, just like Xarelto. Usually the normal dosage is 5 milligram two times a day, unless you have a client who's older, a patient age greater than 80, or creatinine is more than 1.5 and their weight is less than 130 pounds. Then we start with a 2.5 milligram 2 times a day. Otherwise healthy individual who's not meeting these three criteria, the dosage is 5 milligram 2 times a day. And with the Pradaxa, the mechanism of action is very similar to heparin, which is direct thrombin inhibitor, but this is not injection, this is not IV, this is a PO drug, and the dosage is 150 milligram 2 times a day. If you have a client with renal impairment, then we lower the dose to 75 milligram 2 times a day. And contraindication would be just like with the Xarelto, creatinine clearance of less than 15 ml per minute. All right, so all of the drugs that we have covered so far, they were under anticoagulant classification. Now the next classification is antiplatelet drugs. Now, so what's the difference? Remember in the beginning I mentioned that when you have an injured blood vessel, platelet, they come to the scene to start making a plug or a clot, if you will, right? So I mentioned that platelets, they have a natural affinity towards injured blood vessel. So we can say that antiplatelet agents such as aspirin and Plavix, they will prevent the aggregation. They will prevent the blood clot, if you will, formation of the clot, right? Now, one thing is important to understand is that the main difference between anticoagulants and antiplatelet agents are that antiplatelet, they are more effective against arterial thrombosis, whereas anticoagulants are more effective against venous thrombosis. Now, what do I mean by that? If we have a blood clot in the venous system, such as a DVT, let's say, deep vein thrombosis, if there's a blood clot in the venous system, we usually give anticoagulant medications such as Warfarin, Xarelto, Eliquis, Pradaxa, Heparin, and Lovenox, and so forth, right? Same thing with the PE, because the issue is thrombosis in the venous system. However, if we are dealing with the potential clot in the arterial system, such as in the setting of MI or a stroke, we would consider antiplatelet agents at that time. So two examples again, aspirin and Plavix. The generic name for Plavix is clopidogrel. I have covered both of these medications in pain management under pain management lecture, so make sure you review that, please. The basic principle here is both of them are platelet aggregation inhibitor. Plavix is more stronger than aspirin. Rule of thumb is if you have a patient on one of these medications and the patient is scheduled for surgery, let's say, we are going to hold these medications for 5 to 10 days, 7 to 10 days or so, because that is the average lifespan of platelets. Very important concept that during a couple of days before surgery, we usually hold anticoagulant medications as well, but that is a very individualized plan, as far as when do we hold Warfarin and Plavix and so forth. Also, please understand, if the patient is on multiple agents, then the overall risk of bleeding is high. So for example, let's say the patient is on let's say Warfarin or Xarelto for DVT, and also on either aspirin or Plavix because of the history of CVA or MI, then overall risk of bleed is huge. So very important concept and important patient education to watch for those bleeding symptoms, such as a GI bleed, blood in the stool, or blood in the urine, or maybe brushing, when you brush your teeth and then your gums are bleeding, or nosebleed, and so forth. Okay, one more side topic here: the use of aspirin and Plavix in the setting of intermittent claudication. The management approach for intermittent claudication is multi-approach. So let's see what is intermittent claudication first. Well, this is just a fancy name for pain or cramping in the legs that gets worse with walking or exercise. It is a primary symptom of PVD. So you have a client with a peripheral venous disease, or vascular disease, I should say. The pain is due to plaque, atherosclerosis, built up in the blood vessel that block oxygen supply to major muscles in the leg. So treatment approach would be, of course, lifestyle modification, quit smoking if the client smokes, exercise, controlled other comorbidities such as blood pressure, hypertension management, diabetes, and plus minus use of aspirin or Plavix in that case. All right, so the last category is thrombolytic agents or fibrinolytics. This is a process that remove thrombi. Remember, all the drugs that we have discussed so far, heparin or warfarin, they will not dissolve the clots. They will not digest the existing clots. They prevent the new clots or prevent the enlargement of existing clots. So a totally different type of approach or a drug is needed to dissolve or burst the existing clots, and that's where these drugs are all about. So so sometimes we call them like a clot busters, if you will. The mechanism of action is that these medications will convert plasminogen to plasmin, which then dissolve fibrin clots, right? So remember, at the end of the day, we're trying to dissolve the clot. These medications, they carry extreme risk of a bleeding. So we have to be very, very careful that the patient is already not bleeding. These medications are usually reserved for life-threatening illness. For example, maybe you have a client with a pulmonary embolism, and that clot is blocking the blood flow, and we need to dissolve that clot. Same thing with MI or a stroke. But we always want to make sure that the patient is not bleeding. When we give this medication, the patient must remain lying down up to 8 hours or so due to severe side effect of hypotension or hemorrhage. All right, so the examples, the older example is streptokinase, a lot of side effects and so forth, with a very slow onset. But the newer drug are safer, but still carry a huge risk of bleeding, by the way. Altiplase or Activase is used a lot. So when we have a client who is meeting the criteria, Drug should be given within 6 hours of MI and within 3 hours of thrombotic stroke. We always want to rule out intracranial hemorrhage, as I mentioned. Otherwise, the risk of bleeding is pretty huge. Sometimes Activase is used off-label if you have IV catheter blockage and we want to restore the potency. Sometimes we use Activase at that time. Okay, so this last slide is just giving us a recap of different sites of mechanism of action for the drugs that we talked about. Remember, we started with heparin. So here's a site of mechanism of action. Then we talked about low molecular weight heparin, like Lovenox and so forth. So here's a site. Then we also talked about Warfarin with the vitamin K inhibitors. Then we talked about Xarelto with factor XA and Pradaxa here. Then at the end we were talking about those clot busters, Antiplatelet right here. So take a look at this diagram, and then hopefully this will provide you a very good summary of different drugs that we discussed today. That's all I have. If you have any follow-up questions, please do not hesitate to contact me. Thank you so much for your time.